There are two main reasons for the Canadian government's provision of health services to the Aboriginal population in Canada. First of all, it is clear that medical care was provided to Aboriginals not simply to improve their quality of life, but in order to legitimize and justify colonial relations. Backed by notions of racial superiority and the belief that Aboriginal health could only be achieved through assimilation, medicine, its perspective, and its practitioners have been instrumental in shaping colonial relations. The government often emphasized that they were not bound by any treaty or law to provide medical services to First Nations, but they simply did so out of humanitarian obligations. This moral justification continuously laid the basis for colonial efforts to assist the native population to become integrated Canadian citizens. The second reason they called for immediate attention towards Aboriginal health was the fear of disease spreading to the non-Aboriginal Canadian population. Throughout the first half of the 20th century, rates of disease and death amongst Aboriginal population remained extremely high, especially in regards to infectious diseases such as tuberculosis. Despite government efforts, nationally, by 1942, the Aboriginal death rate from tuberculosis was 15 times greater than that of the Canadian population as a whole. Medical policy towards Aboriginal health in Canada, especially during the first half of the 20th century, was primarily based on methods of isolation. Dr. Peter H. Bryce, appointed Chief Medical Inspector for the Department of Indian Affairs in 1904, continuously suggested the necessity for the removal and isolation of sick Aboriginals, both in regards to decreasing the spread of contagion and facilitating the people's civilization, which was seen as one of the main causes for disease. Bryce's 1907 report on the Indian schools of Manitoba and the Northwest Territories revealed that 24% of all residential school students had died from tuberculosis. He found an intimate relationship between the health of the pupils while in the schools and that of their early death subsequent to discharge. Bryce realized that the health of children upon admission was rarely examined and that principals and physicians often ignored the danger of admitting students with tuberculosis. In Bryce's recommendations, he stated clearly that the government was to blame directly for the poor health of the school children. He then went on emphasizing the importance of sanitation and isolation by suggesting that small tents should be placed alongside schools to prevent children with tuberculosis from contaminating other children as well as their Aboriginal communities upon their return. The department's response to Bryce's suggestions was that they were quite inapplicable to the system under which these schools are conducted. This reflects the government's main concern of assimilation and little regard towards the actual health of Aboriginals. During an era where health services were beyond the means of most Canadians, the Department of Indian Affairs had no interest in Bryce's costly suggestions. It was only at the end of the 1920s that the government began to seriously address growing public concerns of contagion and that Bryce's suggestions of isolation were put into place. In 1930, the Canadian government sought to increase control over reservations by amending the Indian Act yet another time. This amendment allowed personnel of the Department of Indian Affairs to enter into the home of any Aboriginal suspected of being sick with a transmittable disease, and also permitted the forcible hospitalization of any Indian suffering from tuberculosis, trachoma, or venereal disease. This not only further asserted colonial domination, but also facilitated assimilation through the removal and isolation of Aboriginals into hospitals and sanatoriums. Following the Second World War, tuberculosis control became the centerpiece of Indian health policy as the state became committed to a strategy of Aboriginal isolation and exclusion in pursuit of white national welfare. By 1945, $12 million was to be spent on Indian hospitals, residential schools, nursing stations, and other institutions of isolation. But despite these efforts, tuberculosis still remained rampant, and many Aboriginals still lacked access to medical services. The exclusion of Aboriginals from proper community hospitals was due mainly to race and the fact that hospitals were becoming more and more bureaucratic, therefore adopting a policy to devote bed space to the right patient, the paying patient. With the belief that confinement created healthy, self-governing citizens and broke up the native customs seen as root causes to disease, certain social criteria determined who received care in sanatoria and hospitals. Aboriginal people deemed insufficiently educated to benefit from rational citizenship would be declined treatment, as for young residential school students whose families had demonstrated improvements towards assimilation would be admitted. Although institutions were essential tools to assimilation and dealing with the Aboriginal tuberculosis problem, there was a large population of the disease that were deemed hopeless cases and were therefore either segregated on reserves or residential schools that often functioned as sanatoriums. It was here in these reserves and residential schools that the most concentration of disease was located. Aboriginal children's health was rarely inquired to upon admission to residential schools, and conditions within these were extremely unsanitary, with pus and blood often found on the sheets and lack of ventilation. It was in these abysmal conditions in close quarters with the disease that children often contracted tuberculosis and eventually spread it upon their return to their communities. The Aboriginal health policy of containment was clearly focused less on the actual well-being of Aboriginals in Canada and primarily on colonial incentives, as well as isolation of the sick Aboriginal from the Canadian population. From missionaries to governmental health services, the colonial incentive to assimilate the First Nations population into dominant society has always been at the heart of Aboriginal healthcare in Canada. Along with the fear of contagion amongst Canadian communities, it was these incentives that led to the provision of governmental health services to Aboriginals in Canada. The overall effort to prevent the spread of disease with the provision of health care to the Aboriginal population, along with policies of isolation, only led to the increase in disease and the implementation of institutions such as sanatoriums, hospitals, and residential schools, which further facilitated colonial goals of assimilation.